All right, so we are going to start our audio lecture and PowerPoint presentation on Chapter 29, Bowel Elimination. You can find this on page 1006. So as always, we're going to do a small overview of the anatomy and physiology of the GI tract. Okay, so taking it back, we know that we're going to talk about the upper gastrointestinal tract. Okay, so that contains the mouth, the pharynx, the esophagus, and the stomach, right? So the small intestine, we'll talk about the small intestine. So this is a folded, twisted, and coiled tube that connects to the stomach to the large intestine. It's about 1 inch in diameter and about 20 feet long if fully extended, which is crazy. It occupies most of the abdominal cavity. Most digestion and absorption of food occurs in the small intestines. Chyme travels through it slowly by peristalsis. And so chyme is, just think of it like that buildup of that solid mass that eventually turns into stool, okay? Peristalsis is those rhythmic movements of the GI tract that helps the stool make it where it needs to go to get excreted. Peristalsis halts periodically to allow for absorption in the small intestine. So the small intestine is consistent of 3 segments. So the duodenum, the jejunum, and the ileum. Then we move into the large intestine. So this is also known as the colon. It's larger in diameter than the small intestine, but shorter in length. Okay, about 5 to 6 feet for the large intestine. It extends from the ileum of the small intestine all the way to the anus. It contains 7 segments in that large intestine. So that's the cecum, the ascending colon, the transverse colon, the descending colon, the sigmoid colon, the rectum, and then the anus. And the rectum is approximately 6 inches long, and it is continuous with the anus of the colon. So a highly vascular folded tube. That is what the rectum is, and it's free of waste products until just before defecation, which means poop. Okay. So the process of bowel elimination. So defecation is the process of elimination of waste. So pooping, putting it into normal terms here that we're used to. So when fecal matter reaches the rectum and causes it to distend, those stretch receptors are stimulated to start contraction of that sigmoid colon and rectal muscles. The internal anal sphincter relaxes. And then at that same time, sensory impulses transmitted to the central nervous system produce a conscious urge to defecate. And that's that feeling that we all know, right? And then that causes voluntary contractions of the diaphragmatic and abdominal muscles. And that creates that downward pressure, while at the same time relaxing that anal sphincter and allowing the feces to be propelled through there. Okay, that is the process of bowel elimination. If that signal to defecate is ignored, the reflexive contractions ease for a few minutes until mass peristalsis occurs again, and then you get another pain like that. Also, just to note the Valsalva maneuver. So this is when a person can increase the pressure to expel feces by contracting those abdominal muscles or straining, as we all know, while maintaining a closed airway. Okay, so holding your breath. This is called the Valsalva maneuver. Okay, so what are some factors affecting bowel elimination? So developmental stage, bowel patterns change throughout the lifespan. Meconium is the very first stool that a baby passes. It's green and black and tarry in consistency. Kids start to control their defecation around 2 years old. And then lots of problems with the GI tract, which we'll talk about later, tend to come at an older time in life, okay? So personal factors can affect bowel elimination. Privacy is so important to most people as they're defecating, obviously, as is to have sufficient time to have a bowel movement without feeling the need to hurry. And so clients who are working in a fast-paced job, like nursing perhaps, may have difficulty even consciously recognizing the need to defecate, and some habitually ignore the need, which promotes bowel dysfunction. Okay. And then there's social cultural factors. So stress has a major influence on motility in the GI tract. It causes diarrhea and constipation, stress, okay? Stress is a primary risk factor in the development of irritable bowel syndrome. This is a disorder associated with bloating, pain, and altered bowel function. Nutrition and hydration. So foods and fiber are super important to bowel function. So regular intake of food promotes peristalsis, okay, which promotes defecation. People who eat on a regular schedule are likely to develop a regular pattern of defecation. Irregular eating creates an irregular bowel elimination pattern. Adequate intake of fiber. So fiber is super important because that promotes peristalsis and defecation by increasing bulk. Okay, bulky foods absorb the fluid and increase the mass of the stool, which allows it to stretch those bowel walls and initiate peristalsis and that defecation reflex. So lots of hydration, lots of fiber, okay? So fluid, speaking of hydration, a minimum of 6 to 8-ounce glasses from 1,500 to 2,000 mils of fluid per day is required to promote healthy bowel function. Inadequate fluid intake or excessive fluid loss, as in diarrhea or vomiting, is going to slow down peristalsis and lead to dry, hard stools that are difficult to pass. And then activity, that's a big one as well. So with this, physical activity seems to stimulate peristalsis and bowel elimination. Sedentary people are likely to have weaker abdominal muscles, and clients with health concerns that limit activities such as shortness of breath or pain or bed rest, they often experience constipation. And then medication. So all oral medicines have the potential to affect the function of the GI tract. You'll notice on the label of every medicine, it'll say side effect, diarrhea, nausea, constipation, very general things. Surgery and procedures. Again, I know that I mentioned this in multiple of our previous lectures, and I'll mention it a million times over. Surgery and procedures. This is one, the GI tract is one that you have to really watch after surgical procedure. Manipulation of the bowel during surgery can cause some sort of dysfunction or difficulty getting back normal function, okay? So abdominal or pelvic surgery in which the bowel is manipulated may result in what they call a paralytic ileus, okay? You need to know what that is. That is a cessation of bowel peristalsis, although, so there's no movement in that peristalsis to move the stool down. A paralytic ileus is what that's called, okay? And abdominal and pelvic surgeries can help cause that. So although peristalsis halts, the bowel continues to produce secretions, but without peristalsis, those secretions remain stagnant and they cause distension and discomfort. So paralytic ileuses are not good. To decrease the complications of a paralytic ileus, we want patients who've had bowel surgery typically to have an NG tube, which you guys will learn how to put in lab. And then typically that NG tube, it's a tube that goes from your nose into your stomach, and they hook it up to suction so that it sucks out whatever's in there. So they hit that with low intermittent or continuous suction, and it removes those secretions until peristalsis, until it returns. And then pregnancy. So morning sickness, who knows morning sickness? I know that I did when I was pregnant. So periods of nausea and vomiting that despite the name may occur at any time of day. Okay, so pregnancy can cause that. Also, pregnancy during other pregnancy effects on the GI tract, a growing uterus. That growing uterus crowds and displaces the intestines, which increases the level of progesterone, and it slows intestinal motility. Okay. Pregnant women often experience constipation, a decreased appetite, and irregular food intake. They're eating around their feelings of nausea as well. And they just feel full with their belly full of the baby. The increasing pressure of the uterus and the increased blood volume of normal pregnancy increases a woman's risk for hemorrhoids as well. And then pathological conditions, so neurological disorders and cognitive conditions, as well as pain or immobility, can all lead to sluggish peristalsis and the decrease in the sense to urge, the urge to defecate. Okay. So talking about bowel diversions. So a bowel diversion, if you've already, so we know from watching our urinary lecture that a bowel diversion is probably similar to a urinary diversion, right? So a surgically created opening for elimination of digestive waste and products. So instead of eliminating pee like the urinary diversion, we're going to eliminate poop through these, right? So the reason that we would get a bowel diversion, cancer, ulcerations, trauma, or inadequate blood supply. These are all reasons that a patient would get a bowel diversion. A client with a bowel diversion does not eliminate waste via the anus, okay? Output or fecal material, which they call effluent, is expelled through a surgically created opening in the abdominal wall called a stoma or an ostomy. Whoopsie. Okay, so in the same way, a surgically created opening is called a stoma, okay, or an ostomy. So you'll notice that a stoma is the same. They call it a stoma when it's a urinary diversion. It comes out through a stoma. They call it a stoma when it's the tracheostomy that we talked about. That's called a stoma. So stomas are not specific to bowel diversions, okay, but it's the most common one that we probably see most often when we're just using the word stoma. Okay, so there's an ileostomy. So what this is, it brings a portion of the ileum through the surgical opening in the abdomen, and it bypasses the large intestine entirely. Okay, so no waste products goes through the large intestine when they have an ileostomy. Drainage at this level is very liquid, okay, and very continuous. So patients must wear an ostomy appliance at all times to collect that drainage. Okay, an ostomy appliance would mean a bag that they kind of stick to that area so that the effluent comes out of that stoma and into the bag. So again, at the ileostomy level, it's very liquid. So it's important that they wear an appliance at all times. A colostomy. So this is a surgical procedure in the abdomen. The location of the colostomy depends on the consistency of the feces that is eliminated, as well as the need to wear an ostomy appliance. Okay, so the closer the colostomy is to the ascending colon, the more liquid and continuous the drainage will be. So in contrast, a colostomy close to the sigmoid colon on the opposite side of the abdomen will produce solid feces. Okay, colostomies near the rectum, such as a sigmoid colostomy, can often be controlled by diet and irrigation. So the client may not need to wear an ostomy appliance with those. Okay, so just for anatomy, you remember your ascending colon is on the left side of your abdomen. It goes up, transverse goes over to the right side in a horizontal pattern, and then the descending colon goes down. So any colostomy that you're going to see on the left side of the abdomen is going to have more solid stool than those that you would see on the right side of the abdomen. So going into our nursing process, so assessment, how are we going to assess these patients with GI issues? So we're going to take a focused nursing history because bowel patterns vary. We need a nursing history to determine what's normal for each patient, right? So as we interview clients, we're going to pay attention to their reactions to our questions. Many people are embarrassed to talk about discussing bowel function. So we want to tailor our assessments to the client's needs and use language that makes the client comfortable. We never want to use medical terminology when discussing things with patients. We never want to assume that they know more than they did. So we talk to them like civilians. We put everything in a layperson's term, okay? And then we're going to do a focused physical assessment. So physical assessment for bowel elimination includes an examination of the abdomen, the rectum, the anus, as well as characteristics of normal and abnormal stool. So we're going to look at their stool or ask them, when was the last time you had a bowel movement? What was the size, the shape of their abdomen? What was the color of their stool? We're going to listen to their bowel sounds in their abdomen. Okay, those are super important to listen to determine bowel function, and we'll get more deep into that when we get to our physical assessment chapter. You might also palpate the anus and the rectum for presence of a stool mass. And then diagnostic testing. So there's indirect visualization. So this is radiographic views of the lower GI tract. So this is the simplest of tests in an abdominal flat plate. An anterior, posterior X-ray view of the abdomen can detect gallstones, can detect fecal impaction, or a distended bowel. Okay. Other indirect visualizations aside from an X-ray would also include a barium enema, an ultrasound, a CT scan, or an MRI. Okay, those are all indirect visualizations. When we talk about direct visualization, we're talking about diagnostic and treatment purposes. So these are invasive procedures and they require a consent form from the patient. So these are typically conducted by a gastroenterologist who inserts various instruments such as an endoscope to examine the interior of the GI tract. The nurse's role during these studies is to prepare the patient for the test and function as an assistant and provide aftercare. Some of these different kind of testing includes an EGD or an esophagogastroduodenoscopy. Okay, that's a long one, so we just call it an EGD. Okay, what this is a fiber optic tube that goes in through the mouth and is advanced to the duodenum. A sigmoidoscopy is a scope used to view the anal area, the rectum, and the sigmoid colon. Okay, sigmoidoscopy. A colonoscopy. A colonoscopy is a scope inserted through the rectum to visualize the rectum, the colon, the entire large intestine, and the distal small bowel. Okay, so with these ones, this is important to know because these are pretty common that people get colonoscopies. So this one provides the best visualization of most areas of the colon, but it does require a bowel prep. So basically solutions are consumed orally until the bowel is completely cleansed. They don't want any stool in the bowel because they're about to stick an instrument up there. So they take a cocktail of lots and lots and lots of Miralax and different kinds of things to make them have bowel movements. So they have to do a bowel prep. That's what that is. So the colon is completely cleansed and a clear liquid is the only discharge from the rectum. That's all they want, a clear liquid. So diarrhea may be resulting from this bowel prep, and that would be normal. Okay, we want them pretty much having diarrhea after taking all of that is expected. So that would be normal. Okay, a stool for occult blood test. So you can perform this test at the bedside, although some institutions require it be done in the laboratory, but most of the time you can do it at the bedside. This is typically called a fecal occult blood test, where they test the stool for blood. It requires the use of a special reagent that detects the presence of perioxidase, and that's an enzyme that's present in hemoglobin. Okay, so that's how it tests for blood. Only a small smear of stool is required. And it's important to educate your patient on this. So for home testing, we want to remind them to wash their hands before and after collecting stool. Okay. And then checking the stool for ova and parasites. So in assessing a child, typically ova and parasites, if you've ever heard of pinworms, which is pretty common in children, that's kind of where we're thinking with ova and parasites, though it could happen to adults too. But in assessing a child, you would have to spread their butt cheeks while the child is sleeping and examine the anus to see whether there are any pinworms visible to the naked eye. Crazy thing about pinworms is they don't like to come out during the day. They typically come out at night, which is crazy. And it's literally just a worm that lives in their rectum. Craziness. So honestly, this is crazy, but this is probably something they probably do more like in a doctor's office setting. I've never had to deal with this, but they say that in order to see if a child has pinworms in the morning, as soon as the patient awakens, we press clear cellophane tape against the anal opening. And then you can test that tape for the presence of eggs. And that's going to tell you if you have a pinworm infestation kind of in there, which is insane to me. We want to make sure that patients know we're going to remove the tape immediately and put it adhesive side down onto a slide so that we can see what's on there. Craziness. Okay. Test your knowledge. So the nurse knows that the results of a fecal occult blood test can be inaccurate if 1, the client has had excessive intake of red meat, 2, the female client is menstruating, 3, the client takes high doses of vitamin C, or D, all of the above. So again, this is one of those that I haven't given you the answer to this yet. So this again should reinforce the need for you to also look through your book to learn these items. But the correct answer here is 4, all of the above, okay? The fecal occult blood test can be inaccurate if the patient has had excessive intake of red meat, if the client is menstruating, and if the client takes high doses of vitamin C. All of those can skew the results, okay? All right, so when we're talking about bowel sounds, okay, and this is something we'll get really into when we talk about our physical assessment, but you do need to know this. You will learn it more in depth when we talk about physical assessment, but we're listening to bowel sounds. First of all, when we're doing a bowel assessment, we are always going to look with our eyes before we ever touch, okay? Because touching can influence the sounds that we hear. When we are doing our assessment, we're always going to look and listen before we touch. And the reason for that is because once we start touching and palpating these areas, that is when you can manipulate the sounds. If you start palpating the bowel, you might hear more sounds than what are really accurate for this assessment, okay? So we're always going to look first. We're going to inspect with our eyes. What are we looking at when we see their abdomen? Is it distended? Does it look normal? Is it symmetrical on both sides? That's what we're going to do. We're going to look, we're going to inspect. Then after we're done inspecting, we're going to auscultate. So auscultating in nursing means listening. So we're going to listen to the bowel sounds. Okay. And so when we're listening to bowel sounds, if you can take your stethoscope and try this on yourself or your partner or your parent or whatever. And if you just listen into their belly, you can hear these clicks and gurgling sounds. Okay. And a normal bowel sounds occur every 5 to 15 seconds or at least 5 to 30 times per minute. Okay. That's in a healthy adult. So bowel sounds can be normal, or they could be hypoactive, or they could be hyperactive, or they could be absent. Okay, so with hypoactive, we know hypo is below, right? So that's less than 5 sounds per minute. When we're hearing less than 5 sounds per minute, we're thinking this could be constipation. This could be decreased GI motility, right? That's hypoactive. When we're listening to hyperactive, because we know hyper means above, we're hearing more than 30 sounds per minute. So we're expecting diarrhea, increased GI motility, just discomfort all around. Anybody heard of the term bubble guts? That's kind of what it is, hyperactive bowel sounds. And then absent bowel sounds, so no sounds at all. And that's an emergency. So that could be that paralytic ileus we talked about, or a bowel obstruction. Okay, so that's important to know when assessing bowel sounds. And then always keep in mind when you're assessing bowel sounds, you always go in the order that I'm about to tell you. You start at the right lower quadrant. Listen there. You move up to the right upper quadrant. Listen there. You move over to the left upper quadrant. Listen there. And you move down to the left lower quadrant and listen there. So you must listen to each quadrant independently and in that order because it follows the path of the bowel. Okay. And then after auscultating, when we get to physical assessment, you'll learn this more, but so we inspected, we auscultated. After that, we would palpate. Okay, we palpate, make sure there's no masses or anything crazy. So we'll get more into that when we talk about our physical assessment. All right, so we've assessed. Now we need to go to we're doing our ADPI. So now the D for diagnosis. So all of these listed here are different kinds of nursing diagnoses that apply to patients with GI issues. Okay, so these are the approved ones. Again, you can find these in your book. You can find these in your care plan book. Okay. Again, as usual, the general bowel elimination goal is that the patient is going to have soft formed bowel movements regularly. Okay, that's the goal. Very general. We always want a target date. So maybe they'll have movements every day before discharge. You know, you always want to make your goal specific. Okay. So again, this is all specific based on what's going on with your patient. So promoting regular defecation. So who remembers from the reading how much fluid we should consume each day, especially if we're consuming fiber? So it's a minimum of 1,500 mils of fluid per day. Ideally, 2,000 to 2,400 mils per day. Okay, 8 to 10 glasses per day is what it is. Okay, so why water instead of caffeinated beverages? Any idea? So Caffeine has a direct diuretic effect, like we learned in our urinary chapter. So it isn't as effective as water in hydrating your patient. So if your patient refuses to drink anything besides iced tea, it's better than nothing. But we want to encourage water consumption. Okay. So other ways besides fluid intake to promote regular defecation, privacy, like we talked about, we have to provide them with a private area to perform this activity. So that means if they're on the bedpan, we want to make sure that we place them on there, make sure that they're safe, their bed is lowered, they have their call light, they have toilet paper, they are ready to go, and you just let them know, I'm going to give you some privacy. I'll come back and check on you about 10 minutes, or if you call me, if you're done before that, just call me and I'll come back. Okay. Provide privacy. Also the correct position. So who wants to poop laying down? Nobody. That's just not effective. Gravity helps. So as you can see in this picture here, this guy is on the squatty potty, which actually is a real legit thing. And it literally puts your body in this position, which the toilet does not put you in this position, because look how high his legs are up off that toilet. But the squatty potty does. And it is supposed to be the easiest position to go. Okay. So just make sure your patient's seated upright. If you're putting them on the bedpan, don't leave them laying down flat to poop. Sit them up in their bed on the bedpan and let them go that way. Timing. So we know that defecation typically occurs after meals, not always, but sometimes, most of the time. And some clients may need assistance. Okay. So a lot of times they can't do the patients we're taking care of cannot do things like this on their own. So we need to help them. We talked about fluid intake already. So a proper diet, fresh fruits, vegetables, whole grain fiber, okay? All super important for bowel health and regular bowel movements. And then exercise. We need to recommend that they exercise 3 to 5 times a week. And if they're not able to exercise, we need to provide them with range of motion for those clients that are on bed rest so that we can get them moving. So alterations in defecation, diarrhea. This is the passage of loose, unformed, or watery stools. Patients typically present with stomach cramps and hyperactive bowel sounds due to hyperperistalsis. Okay, that's diarrhea, hyperperistalsis, right? Constipation, because frequency of bowel elimination varies, constipation is usually defined as a decrease in the frequency of bowel movements, resulting in the passage of hard, dry stool. Okay. It can be temporary, where symptoms may resolve over a short time, but nearly everyone experiences constipation at some point in their life. Chronic constipation typically lasts 3 months or longer, but may persist for years. Patients typically present with a complaint of abdominal cramping, pain, distension, or fullness, and may have hypoactive bowel sounds, right? And then fecal impaction. So this occurs when dry, hard stools are lodged in the rectum and cannot be passed. You see this quite a bit in the older populations where we have to manually disimpact our patient. And I'm going to leave that to your imagination what that means. And then bowel diversions. We talked a little bit about that, but I've got a video at the end of this PowerPoint that will go in great depth about that. So again, going on with the alterations in defecation. So diarrhea, what are we going to do about it? This is our interventions. What are we going to do about it as the nurse? So we're going to monitor stools to quantify diarrhea. Okay, so we're going to assess the frequency, the amount, the color, and the consistency of stools to determine the severity of the diarrhea. We're going to assess and monitor for fluid imbalance, right? Because when our patients are having diarrhea, they're losing fluid as well. That can cause them to be dehydrated, having such bad diarrhea. We're going to also, so monitoring for fluid imbalance, that includes monitoring intake and output, monitoring body weight, assessing vital signs, assessing skin turgor, okay, which we'll learn about in our physical assessment chapter, but that's where you pinch on a level of skin, and it either, if it tense and stays there, that means it's not hydrated well. And if it goes back to its original supple position, then it's a good sign of hydration. Okay, so we're going to test skin turgor and also look at the moistness of their mucous membrane. So look at their mouth. Does their mouth look dry? That would tell you if they're dehydrated, right? And then monitor for alterations in perineal skin integrity, right? So just like urine is acidic, diarrhea is very acidic. Okay, so we're going to assess the perineal area for alterations in skin integrity. So clients with diarrhea are going to experience perineal irritation and excoriation. So we want to make sure we keep their skin clean and dry. We're going to do proper dietary teaching. So a clear liquid diet, including electrolyte replacement fluids like Pedialyte or sports drinks, clear broth, gelatin, bananas, rice, applesauce, toast. So the BRAT diet, if you've ever heard of the BRAT diet, bananas, rice, applesauce, toast. That is a great recommendation for patients who are experiencing diarrhea because it keeps the food dyes out. It makes the colon not have to work as hard to digest food. It's very bland, easy to digest food. Okay. So the BRAT diet is great for patients with diarrhea. Also, yogurt. Yogurt has probiotics to promote gut health. So that's important. We want to recommend that they avoid fruits and vegetables if they have diarrhea because there's so much fiber in them. That's just going to promote further defecation. Okay. And then anti-diarrheal medications. These are not recommended for acute diarrhea. And acute diarrhea just means like if you have a GI bug. Okay. We're not going to use Imodium for a GI bug because diarrhea is a response to an infection or unusual foods or something, and it serves as a mechanism to get rid of that pathogen from whatever it is you've got infected by. So by taking Imodium and stopping those bowel movements, you've now stepped in and kind of ruined your body's protective instinct where it was trying to rid the body of that pathogen, and you've stopped that. Okay. Although anti-diarrheal medications are available without a prescription, we need to caution patients to avoid using them unless they talk to their healthcare provider. Medications usually reserved for patients with chronic diarrhea. That means it's persistent for longer than 1 month. Okay, and then constipation. When we are talking about that, what are we going to do about it? We're going to increase the intake of high fiber foods, fruits, vegetables, a fiber supplement, lots of things like that. We want to encourage fiber on patients that have constipation. We're going to increase their fluid intake, right? Fluid intake needs to be perfect. It needs to be a lot in order to soften up that stool. We're going to increase activity and exercise. Movement causes good motility. We're going to provide privacy because, again, a lot of times the privacy issue could be why they're not going. Right? They're ignoring that urge to defecate because they don't have enough privacy. And we're going to help the client into a position that facilitates defecation. Okay. Again, an upright position. Okay. And then allow uninterrupted time. Allow them time to use the toilet, especially after meals. Okay. Offer laxatives when lifestyle changes are ineffective. Okay. And in a medical setting, they will require a prescription for that. All right. So test your knowledge. Miss Addie is 70 years old. While the nurse is gathering admission assessment data, the patient states, I've taken a tablespoon of milk of magnesia every day for 3 years. What nursing diagnoses is most appropriate for the nurse to use in her plan of care? 1, diarrhea. 2, constipation. 3, risk for ineffective therapeutic regimen. Or 4, perceived constipation. So let's look at the answer here. The answer is perceived constipation. So daily laxative use by the patient might suggest that she thinks she's constipated, and the nurse would gather further assessment data related to the client's bowel pattern, but there's not enough data in this question to infer that there is actual constipation. Okay, so she's perceived, she hasn't even given herself a chance to become constipated. She's taken Milkamag every day for 3 years, you know? So perceived constipation. Okay, so enemas. These are fun. These are fun nursing interventions here. I just love to teach you guys to just do this stuff. So an enema is the introduction of solution into the rectum to soften the feces, distend the colon, and stimulate peristalsis and the evacuation of feces. Okay, we're giving this to patients who are constipated, right? So cleansing enemas, there's a couple different kinds of enemas. So cleansing enemas, these promote removal of feces from the colon. They have the following uses. They treat severe constipation or impaction. They clear the colon in preparation for visualization procedures such as a colonoscopy. They empty the colon when starting a bowel training program. And they clear the colon for surgeries of the lower GI tract and for some different kinds of pelvic surgeries. Okay. There's also retention enemas. So these introduce a solution into the colon that is meant to be retained for a prolonged period. Okay. Consequently, the volume is small, like 90 to 120 mils or so. So typically, you're putting in that enema and you tell them pretty much hold on tight, clench your butt cheeks together for 20 minutes or however long, and then they should get the urge to defecate at some point from that. So there's different kinds of there's different kinds of retention enemas. So like oil retention enemas, these ones use oil that go into the rectum, and that kind of works as like a lubricant. There is also medicated enemas. So these may be used to instill antibiotics to treat infections of the rectum or the anus. And then there's return flow enemas. So these are known as a Harris flush. So may be ordered to help a patient expel flatus and relieve abdominal distension. So for adults, approximately 100 to 200 mils of tap water saline is instilled into the rectum. And that's a return flow enema. So much fun. Okay, so disimpaction. So we talked a little bit about that in a couple of slides. I said I'd leave it up to your imagination with this one. So manual or digital removal or disimpacting. This is unfortunately one of our job duties. And this is digital removal is accomplished by breaking up the hardened mass of stool and manually extracting the pieces. So this means your gloved and lubricated finger is in their rectum and you are trying to break up their stool so it will come out. And yes, that is the thing. And we do that. Sometimes nurses will give an oil, or they'll get an order from the physician for an oil retention enema at least 30 minutes before that to help the patient's discomfort. Always remember that obviously if you're getting to the point where you have to disimpact your patient, we need to establish a bowel program to prevent recurrence, okay? Because this has got to be a problem. So let's treat the problem instead of keep having to digitally disimpact our patient. And so bowel incontinence. So clients with persistent bowel incontinence require specialized nursing care to prevent impaired skin integrity because of the moisture and acidity of enzymes in the stool. Okay. So in addition, bowel incontinence may be embarrassing. Also, I'm sure that it is. Clients will worry about having future episodes and it will cause them to have anxiety. Okay, so there are some things here for bowel incontinence. So external fecal collection devices. So if anybody's ever heard of a rectal tube, that's what this is. Okay, so you may apply an external fecal incontinence pouch to protect perianal skin to collect large fecal samples. So that's like a bag, I guess. I've never seen that in real life. I've seen the tubes, but never the bag, but that's a thing. This is a common approach for clients with uncontrolled diarrhea. Okay, the pouch collects fecal drainage, keeping feces away from the skin in order to preserve their skin integrity. Pouch systems vary widely, and these types of pouch systems are contraindicated for ambulatory patients, so they can move on their own, or the ones that are very active in bed because they move too much and they will dislodge the device, and that alone will cause skin breakdown. Okay. So indwelling fecal drainage devices, these are the tubes. So these are used to collect liquid stool from bed-bound, immobilized, and ill patients. They consist of a soft latex-free catheter and a collection bag. Okay, so the tube is inserted and a balloon on the end is filled with saline or water. And that's what you're seeing here in this picture on the right of your screen. That's how it's almost kind of like a Foley catheter, I guess. And that's kind of how it's just like anchored into the rectum, right? So the tube's inserted, the balloon on the other end is filled with saline. These indwelling fecal drainage devices are contraindicated in children in severe hemorrhoids, and in recent rectal, anal, or bowel surgeries or cancers in those areas. Okay. And then a bowel training program for bowel incontinence. Just like for urinary incontinence, we had recommended a bowel training program. We are also going to recommend a bowel training program for these patients with incontinence. Okay, so with that, we'll go to the next slide because I do have some information on that. Okay, perfect. So what's our goal with this bowel training program? Our goal is for the patient to have regular soft form stools. Okay, we want to plan the program with the client, right? So we want to make sure that there's a designated time for the stools. The best that we can plan for uninterrupted time. Okay, it works best after meals and in the morning. That's what we're trying to do, right? We want to increase the fiber in their diet gradually. That's part of the bowel training program. We want to increase fluid intake to 8 to 10 glasses of water per day. Establish a designated time for defecation, like we said. Privacy should be provided. We want to do a staged treatment plan, right? So first, we want to add additional fiber. Second, maybe we want to add a stool softener. Third, maybe we want to add a suppository. Okay, so we kind of goes up in, we kind of up the ante each stage, right? And so with stool softeners, these can be given to soften the stool. There's different kinds, Miralax and Ducalax, and different kinds of these. You can see in box 29-1, the different kind of laxatives. Okay. We want to help patients understand that laxatives work by stimulating peristalsis, but this can also cause dependence as well as decreasing absorption of certain vitamins. So we never want to recommend that people take laxatives regularly because it can cause dependence, okay, to where their body does not defecate unless they're taking the laxative. So managing a bowel diversion. So remember this right here to the right hand of your screen, that is a picture of a bowel stoma. So a colostomy stoma, right? So we need to pay strict, I cannot say this enough, strict attention to the skin care and the peristomal skin assessment. So that means the area around the stoma, the skin around the stoma. This should be a very important part of our assessment. Okay, so the stoma should be a deep pink color or a brick red and should be shiny and moist. Okay, it will be permanent size at 6 to 8 weeks after surgery. Before that, it's a little swollen. Okay, so the presence of enzymes in the effluent increases the likelihood of skin breakdown. So that's why skin assessments are so important. As we talked about, ostomies lower in the GI tract have more formed stools with less enzymes. So the more liquid the stool, the more irritating to the skin it's going to be. We're going to assess the skin surrounding the stoma for signs of irritation, such as redness, tenderness, skin breakdown, and or other drainage. Okay. Stoma should never be black in color. That's an emergency. This should never be black. Always red, pink type color. We're going to monitor the amount of effluent that comes from the stoma. So we record it as part of our output. Okay. We also want to be attentive to the client's psychosocial needs. So be professional, show acceptance, be very matter of fact, like this is just business, no judgment. Okay. Attend to odor control. It's a very important intervention to help with the self-esteem of our patient. Okay. How would you feel if you were walking around with a bag of stool connected to you and people made fun of you because it smelled bad? Okay. So we want to make sure that we try our best to help them avoid that kind of situation. And we want to address the client participation in ostomy care. So remember, in a short-term ambulatory setting like a hospital, hopefully in theory, they're going to go home at some point. So we want them to be a part of colostomy care because they're going to have to do it themselves at some point, right? Okay. Test your knowledge. So you're caring for a patient with a colostomy. In order to provide safe care, you understand that when irrigating a colostomy, a proper fitting cone is needed to prevent what? 1, introducing air into the colon. 2, leaking the solution around the stoma, 3, administering the solution too rapidly, or D, or 4, introduction of bacteria from the stoma. Correct answer. So a proper fitting cone prevents leakage of the solution around the stoma that may cause irritation and damage to the skin around the stoma. So when we talk about irrigating, basically what that means is you're just like shooting liquid from like a syringe, I guess, not like a shot syringe, but a bigger syringe. So we'll learn how to irrigate wounds and things in lab. But you're basically, when you're irrigating, just think of it like you're using a syringe to shoot water at something to kind of rinse it off. Okay, that's what it is. So we want to make sure that we get a proper fitting cone for patients with colostomy to prevent leakage of that solution around the stoma. Okay, here's another one. So the nurse is assisting the client in caring for her ostomy. The client states, "Oh, this is so disgusting. I'll never be able to touch this thing." The nurse's best response is, just remember, this is one of those therapeutic communication questions that you'll see on your NCLEX a million times, right? So these are the ones you need to get used to. So I'll let you think for a minute. So 1, I'm sure you will get used to taking care of it eventually. Or 2, yes, it's pretty messy, so I'll take care of it for you today. 3, it sounds like you're really upset. Or 4, you sound very angry. Should I call the chaplain for you? So breaking these down, option 1, I'm sure you will get used to taking care of it eventually. We never want to offer false hope, okay? Never when we are communicating should we offer false hope, okay? And that just, it sounds like a statement that's just trying to just get past this and let's just get it done. We don't ever want to do that. Option 2, yes, it's pretty messy, so I'll take care of it for you today. We never want to say, yes, it's pretty messy. Okay. And also, we don't want to just take care of it for her today. Remember, she has to learn how to take care of it herself because we're going to be sending her home. Option 3, it sounds like you are really upset. That sounds like the winner to me. It's very matter of fact. You've offered no judgment, and that gives her a chance to counter you and tell you and open up. And then option 4, you sound very angry. Should I call the chaplain for you? Though that is probably your closest distractor, because I can see some of my students choose that one a lot. The fact that she says you sound very angry sounds a little judgmental, okay? And asking to call the chaplain for that, we just want to make sure that we are letting them aware. It sounds like you're very upset. Leave it open so that they can communicate their feelings, okay? Those follow the principle of therapeutic communication. All right, we're going to go ahead and watch this video. And it's quite a long one, so feel free to take a break and pause as you need to. I'm trying to see if I can make this fit on the whole screen for you. This darn thing's not wanting to open. Okay, hold on just a moment. Get this plan. I do recommend you stick around to watch this video because this will really help you understand colostomies. Now it is kind of long, so like I said, you may want to take a break right now, come back and play this, but it is important for you to see.
I currently use the Convex Flip. This new product has a grip like none other. It fits so well and it fits so
I'm going to stop this share and I'm going to try to share this screen. So let's see if this works. I hope this does. If not, I will double check and I would post it in a separate screen, but hopefully this will work. So let me share my screen.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to be doing an NCLEX review over GI ostomies, specifically colostomies and ileostomies. And as always, in the YouTube description below or at the end of this YouTube video, you can access the free quiz that will test you on GI ostomies. So let's get started. So what is a colostomy or an ileostomy? It is a surgical opening created on the surface of the abdomen to allow stool to exit the body rather than through the rectum. And here is what a basic GI ostomy looks like on the surface of the abdomen. And notice that you have the stoma, and the stoma is setting right on the surface of the abdomen. And in the middle, this is where the stool will be excreted. And you always want your stoma to look nice and red like this. It'll have a shiny look to it and be moist. So what are some reasons why a person may have an ostomy? One thing is they may have GI disease like Crohn's, ulcerative colitis, or diverticulosis, or an infection or cancer like colon or rectal cancer, or maybe an injury or congenital defects like an obstruction. And a colostomy or an ileostomy may be permanent or reversible depending on what's going on with the patient and their treatment plan. Now, before we dive into our lecture about colostomies, ileostomies, and the nursing care, let's go back to the basics. Let's look at the anatomy and physiology of the GI tract and how food flows through the system. And as I do this, be sure you pay attention to the small intestines, specifically the ileum and where it's located, and the parts of the large intestine, like the colon areas, because this is where your ostomies are going to be located, and you need to be familiar with those locations. So, whenever you eat food, digestion starts in the mouth. So you eat food, you chew it up, your saliva's mixing with it, it's breaking down the food a little bit, and then you're going to swallow it. And you're going to swallow it down through a tube called the esophagus. And the esophagus is going to use peristalsis to get that food down into your stomach, which is like a pouch. And in that stomach is gastric acid. And it's going to mix with your food, and it's going to break it down a little bit, and it's going to turn into a substance called chyme. Then it's going to go through the small intestine. And the small intestines are responsible for absorbing and digesting your food. That is its huge role. So the food's going to enter into the first part of the small intestines called the duodenum. Then it's going to flow down through the jejunum. And then it's going to go through the last part of the small intestines called the ileum. And the ileum is where our ileostomy will be. Then the food will flow into the large intestine. And colon is also called large intestine. It's going to enter in through the cecum, up through the ascending colon, across the transverse colon, down through the descending colon into the sigmoid colon. And your large intestine, the big role it does is it absorbs water. And it helps get the food that your body didn't use, the waste, and forms it so you can pass it as stool through the rectum, then to the anus, and then out. So that is how the basic setup of how food will flow through your GI tract. First, let's start out talking about colostomies. Okay, we know that a GI ostomy is where a surgical opening has been created to bring some part of the intestines to the abdominal surface so stool can be excreted rather than through the rectum. Well, a colostomy is a surgical opening that brings the large intestine, the colon, to the surface of the abdomen. Now, there are various locations for a colostomy, so different types, and I would remember these types because you need to know them for when you're assessing a patient with a colostomy. If you see it on the right side, the left side, mid-abdominal, you need to know what type of colostomy that is and what type of stool you would be expecting from that colostomy, because depending on its location, there's going to be different varieties of stool, which we'll talk about a little bit later. So let's talk about the types. Okay, to help you remember the different types, remember this mnemonic. That's a colostomy. D is for descending. So when you have a descending colostomy, it will be located in the left upper abdomen. So we have our descending colon, and you could expect one about right here. Then we have our ascending, and you could expect an ascending colostomy to be on the right area of the abdomen. So over here on the right side where the ascending colon is, you would expect one about right here. Then we have a transverse colostomy, and you will expect that about mid-abdominal. So you have your transverse colon, so about right here is where you would expect that. And then we have a sigmoid colostomy, and this can be found in the left lower area of the abdomen. So we have our sigmoid colon right here, so about right there. It would be a little bit lower than your descending colon, so you could expect that right there. Now let me discuss this real fast with you. It's called a double barrel ostomy, and it's part of the transverse colon, so you would find one about up in this region, and it is the creation of two stomas. And let me show you what one looks like. As you can see here, we have two stomas, and the stomas are nice and red, they're moist, they're shiny, which is how we want them to look. And I would remember this part. Okay, we have the proximal stoma and we have the distal stoma. And the proximal stoma is connected to the upper GI tract, so it's functional, and it's going to be draining stool. So that's what we will expect out of here. But over here with our distal, it's connected to the rectum, and it's not functional. Sometimes it's referred to as a mucus fistula. So what you will expect to come out of here would be mucus. So if you're ever asked on a test, patient has a double barrel ostomy, what do you expect the proximal and the distal to drain? You will know that the proximal drains stool and the distal will drain mucus. And so that's what your classic double barrel ostomy will look like. Now let's talk about an ileostomy. Okay, an ileostomy is a surgical opening that has been created to bring the small intestine, specifically the ileum, to the surface of the abdomen so stool can be excreted. And an ileostomy is going to be located in the right lower quadrant. So you can expect one to be about right here on the abdomen. Now let's look at the pre-op and the post-op nursing care that you will be providing to that patient who may be getting an ostomy. Okay, so the pre-op. Okay, what are you going to do as the nurse? Number one, your role is educating. You want to sit down with that patient. You want to talk to them about how the ostomy is going to look. You don't want them, the first time they see an ostomy stoma is right after surgery. That'll really scare them. So they need to be familiar with what's going to happen. Where it's going to be located at on the abdomen. Diet, what kind of diet they need to follow, which we're going to cover in the post-op part of this lecture a little bit later. And the pouching system of how it's going to work with placing the pouch on, how to do that. Because at first it can be really confusing and overwhelming for the patient. So if you introduce them to that a little bit in the pre-op part, when the post-op part comes and they actually have to start participating and taking over care for that, it won't be so overwhelming. And I'm going to be making a video on how to place an ostomy pouch and how to provide care. So be sure to check out that video. Okay. Another thing, the MD may order oral antibiotics. Why? Because in your gut are all these bacteria that normally live there. But when you go in and you do surgery and you mess around with those, you can cause some problems. So the antibiotics will help decrease the bacteria in the colon and decrease the chances of post-op infection. And also the physician may order the patient about 2 to 3 days prior to surgery to be on a soft or semi-liquid diet. Also may order cleansing solutions to cleanse the colon, get it all cleaned out before they go in there and do surgery. Don't want any residue of food in there. And they also may be on a clear liquid diet 24 hours before and then nothing by mouth. And a lot of times patients are admitted to the hospital because they're going to be on these cleansing solution, which is going to cause profuse diarrhea, and they're at risk for electrolyte imbalance and dehydration. So they will probably be on an IV solution to help balance that out. Now let's look at the post-op care. Okay, so your patient's back, they've had their ostomy placement. What is your role as the nurse? Okay, you're going to monitor their electrolytes. You're going to monitor them for signs of dehydration. So you're going to be looking at that urinary output, making sure that they're stable, they're doing good, and they're tolerating everything. Also, big thing what you want to do is you want to monitor that site, specifically that stoma. And what you're looking at is how does the stoma look? So how should it look? After surgery, the stoma is going to be large and swollen. And you need to let the patient know that as months go by, the stoma will shrink down to normal size. But at first, it's okay. It's going to be large and swollen. Now, the stoma should always look pink or red, like how I showed you in that example of red, and be moist and shiny, like the inside of your cheek, of your mouth. Abnormal. I would remember this. Test questions like to give you a scenario about how a stoma may look and what it shouldn't look like. So if the stoma appears to be black or dark red, that could indicate, well, it indicates compromised circulation to that stoma. Not good. You need to contact the doctor immediately. And let's look at a stoma that has compromised circulation versus a stoma that is nice and healthy. And I want you to see the difference. Over here we have an ostomy. This does not look good. This has compromised circulation. So if you ever see it's turning black or a dark red, not good at all compared to how you want it to look. So just looking at the difference, you can really tell that something just is not right over here compared to over here. Also, you want to make sure the stoma does not look light pink. That can indicate a low hemoglobin or hematocrit level. So anytime those types of stomas present, you'll want to notify the doctor. Okay, so what kind of drainage do you expect your ostomy, depending on if it's an ileostomy or colostomy, to have after surgery? Okay, an ileostomy, remember it's going to be located in that right lower quadrant. It's going to drain dark green stool. And as the patient, whenever they start to eat and tolerate food, they'll start out slow, clears, fulls, and that stool will start to turn like a yellowish color. Now, the colostomy, at first it may be like a mucousy, mucoid type drainage. And as time goes by, it's normal for it not to really produce anything until about day 2. But at first, it's probably going to be liquid. Then, depending on where that colostomy is located, it'll turn into the form that it's supposed to look like, which we'll cover here in a second. And over the site, you could expect a petroleum gauze to keep the site nice and moist. Also, later on there may be a sterile dry dressing until you get the pouching system in place to start draining the stool. So remember, if a test question asks you, the dressing fell off, what are you going to reapply, or what type of dressing do you expect the patient to come back from surgery? Remember, petroleum gauze dressing. Now let's look at the types of stool that you should expect after the post-op period has passed a little bit, what that site should be putting out. Okay, colostomies. Okay, you have the ascending colostomy. Remember, it's over here. So referring back to the beginning of the lecture when we talked about the food going through the system, remember the food's going through the small intestines and it's liquid, okay? And once it hits the colon, as it goes through the colon, more and more water is going to be absorbed. So remember, the big role of the large intestine was to absorb water. So you can expect if it starts out in the ascending colon, it's going to be liquid because it's just came from the small intestine. So that's how you can expect the stool to be when it comes out of the ascending colon as the ascending colostomy. Now transverse. Now as it travels up through the transverse and you have a transverse colostomy, more water is going to be absorbed. So it's not going to be totally formed. So it's going to be loose to partly formed, semi. Now, as it travels down through the descending into the sigmoid, a lot more water is being absorbed. And it's going to start looking similar to what the patient would expel normally through the rectum, through the anus. So you can expect it to look like a similar consistency to what it should look like normally. Now, keep this in mind. Remember this. The descending and sigmoid colon colostomies, the patient has a greater chance of developing bowel continence where they can learn to control their bowel movements. And why? Because look, normally if stool was going to go in the rectum, you control your bowel movements. So the more distal the colostomy is down in the GI tract, the greater chance of continence that patient has. And they can learn to do this through irrigation, which is just an enema given through the stoma. And I'll be making a video on how to do that, so stay tuned for that. Now let's look at ileostomy. How do you expect the stool to be? Well, as we learn, the small intestine, it's rich in electrolytes, it's rich in water and digestive enzymes. So that stool is always going to be liquid. That's what we expect. And like I said, it's rich in all those enzymes, electrolytes, and water. Now, if you have a patient with an ileostomy because of that, the substance in that being excreted through that, the patient has a higher risk of dehydration because it's not going to go through the colon to be absorbed, so they're losing a lot of water, and electrolyte imbalance as well. And another thing to keep in mind, there is a major risk for skin breakdown around that stoma. Now that's true for the colostomy as well because you don't want that nasty bacteria getting on that skin. It's going to cause issues, but especially with your ileostomy. If it gets on the stoma, it's fine because that's like the part of the GI tract just flipped out. And it's normal. It lives in those conditions normally, but our skin doesn't. So if you get the stool from the ileostomy onto the skin with those digestive enzymes and all that, it's going to get on the skin, it's going to cause major irritation. Notice how around the stoma the skin is very irritated, it's excoriated, and what you want to do is you always want to make sure that the side around the stoma is dry and clean and that stool is not getting on there. And what will really help prevent this is a good pouching system with a really good skin barrier, which we'll discuss in the next video on how to apply that. So always when you're inspecting and assessing as a nurse, always look around the skin and make sure it does not look like this. Okay, continuing with the post-op care that you'll be providing to the patient. One of the big things you need to know is about the pouching system. Here we have an ostomy and it has a pouch over it. This pouch will collect the stool that will drain from it. So as the nurse, you need to be teaching the patient and you need to know how often you will empty this bag, when you will change the system out, and how to change it. So some highlights. Okay, you will empty the bag whenever it becomes about 1/3 to halfway full of stool. Every system's different, so always get familiar with what the patient has or what your employer has for the patient. This one's a clamped. You would undo the clamp and empty it into the commode. Some of them are Velcroed. Some of them you just take off and you have to get a whole new pouch because it snaps on there. The whole pouching system, you will change it about every 3 to 5 days, and around the system is some skin barrier that sets around the stoma to protect it from any drainage leaking onto the skin. And you will change that whole system out, and in the next video I will show you how to do that. And when is the best time to change the pouch on the patient, the whole system? About in the morning, whenever the gut is the least active, so before breakfast. They just got up, they haven't ate, that's usually the best time to do it. And you'll want the patient to report if they feel any wetness around the stoma or if there's any burning. If that happens, you'll want to completely replace the system because you don't want that stool to get onto the skin because it can cause a lot of problems. Now, there's various types of pouching systems. The one I have here is called a one-piece system, and it has the skin barrier attached to the bag. The two-piece systems will have the skin barrier separate in the bag, and they'll just snap together. Now, there's some things you want to keep in mind whenever you're replacing this skin barrier. The skin barrier is going to prevent stool from coming into contact with the skin. So what you'll do is you'll have to measure the stoma with a measuring card. A lot of ostomy kits come with them, so you'll measure the stoma to whatever size it is, and you will cut the opening of the barrier to be about 1/8 inch larger than the stoma. So you don't want the hole to be so small it's constricting the stoma, and you don't want it to be too large that it allows stool to leak onto the skin underneath the skin barrier around it. So remember that 1/8 inch is how much you want to cut it larger than the stoma. Now let's look at medications and diet for your patients with ostomies. Okay, medications, specifically the ileostomy. You do not want to give them enteric-coated or sustained-release medications because where the ileostomy is at, that medication won't be able to work correctly because with enteric-coated, these medications don't dissolve until they release a specific part in the small intestine. So like aspirin enteric-coated, you wouldn't want to do, or other drugs similar to that. And your sustained release are medications released over a certain period of time. So not a candidate for that. And as a side note, you will never want to crush these medications because crushing it is messing up how it's supposed to work because it's made to work whenever it gets to a certain part in the body or released slowly over amount of time. Now diet, let's talk about that. Okay. Whenever you have a patient who just had an ostomy placed, generally they will start out slow with their food for about the first to 6 weeks. Advance things as tolerated, get comfortable, get the gut readjusted to what's going on. They'll start out usually on a low fiber diet. They want to eat small meals throughout the day, not huge, large ones. That's a lot for the gut to handle. And they'll want to chew their food thoroughly because depending on where they have their ostomy at, you know, the food's not getting broke down like it normally could. So they need to help with that process by breaking it down as much as they can in the mouth. And maintaining hydration, especially with your ileostomies, because remember that the drainage that they're draining is rich in water that your colon can absorb and electrolytes. So it's all going out. So they need to make sure that they, drink Gatorade or some type of electrolyte solution to maintain that. And they will eventually be able to follow a regular diet, but they'll probably want to avoid foods that cause them problems before they had the ostomy placed because chances are they'll have problems with it again. And they'll want to use caution with the following foods, like hard to digest foods, because this could block the stoma. So they either need to avoid these foods altogether or eat them in very, very small amounts. And foods like this include corn, peas, cold slaw, popcorn, nuts and seeds, raisins, skin of fruits, and raw mushrooms or pineapple. So just think common sense. What is not normally digested very well? What could get stuck in a little stoma hole that could cause a problem, a patient issue? So if you see a test question, try to look for those options. Okay, also gas. A lot of times with ostomies, they can produce odorous gas. So foods to eat, to avoid from having this gas would be beans, onions, eggs, broccoli, cabbage, garlic, alcoholic beverages, fish, or any types of foods that have high fiber in them. And one thing you'll need to be educating your patient about, because gas is produced, the ostomy bag over time can inflate, and they'll need to know how to release that gas from that bag. And a lot of times they are making ostomy bags that have a filter on them, which will help the gas to escape and it filters out so it doesn't have a smell. Or they can use pouch drops in the pouch to prevent the smell. Okay, so that wraps up this NCLEX review on GI ostomies. Thank you so much for watching. Don't forget to take